Welcome, and thank you all for standing by. At this time, all participants are in a listen-only mode for the duration of today's conference. I would also like to inform all parties that this call is being recorded. If you have any objections, please disconnect at this time. I would now like to turn today's call over to Ms. Karen Francis. Thank you. Please begin.
Okay, well, thank you, and good afternoon, everyone, and welcome to the first webinar for the 2017 Rural Behavioral Health Webinar Series, Depression in Mothers, More Than the Blues. My name is Karen Francis, and I am a principal researcher at the American Institute for Research and lead for the Rural Behavioral Health Initiative, along with my colleagues Joyce Sabian and Laura Fleetwood from the Mental Health Promotion Branch at SAMHSA. This webinar series is supported by the Mental Health Promotion Branch at SAMHSA in collaboration with the American Institute for Research and Affirma Solutions. Thanks again for joining us this afternoon. We're looking forward to learning more about depression in mothers, about what one community is doing to address maternal depression, and about the SAMHSA-sponsored Depression in Mothers, More Than the Blues, a toolkit for family service providers. Our presenters today for today's webinar are Dr. Yannick Edmond, Senior Public Health Advisor at the Center for Mental Health Services at SAMHSA, Dr. Deborah Perry, Director of Research and Evaluation at Georgetown University, Center for Child and Human Development, Flong Nguyen, Young Child Wellness Specialist, Maternal Wellness and Early Childhood Unit, Children, Youth and Family Branch of Colorado Department of Public Health and Environment, and Emily Anderson, Public Health Nurse at Chaffee County Public Health in Colorado. Participants today will learn about the framework and components of the Depression in Mothers Toolkit, learn how the toolkit can be used when helping mothers and their families from diverse backgrounds living in rural communities, and learn about Colorado's approach to promote maternal wellness. We will invite you to ask questions of our presenters midway through the presentation and again at the end of the webinar. You can ask questions of our presenters by typing your question into the participant Q&A box, which is located on the right-hand side of your computer. We will also encourage you to participate in individual chat function, using the chat function to share information, messages, or your thoughts as the webinar progresses. We will try to respond to as many questions as time permits today. Please also note that this webinar, both the PowerPoint as well as the audio, will be posted on the Rural Behavioral Health web portal in about 1 week from today. At the end of the webinar, I will provide you with the link for the Rural Behavioral Health portal. Just a small reminder, we ask that you mute your phones during the presentation so as to avoid any background noise as the presentation is given. Also, please do not put your phone on hold, as we will be able to hear any background music or messages that are recorded on your phone system. So without further delay, I'd like to get us started with just a few polling questions. We want to learn more about the participants joining us today for the call and where in the country you're located. So our first polling question is, okay. So I think that we are experiencing a little bit of technical difficulties here with the polling questions. So I will just then move on and open up the call to Dr. Yannick Edmond.
Thank you, Karen.
All right.
Well, good afternoon, everyone. And for the next few minutes, Dr. Deborah Perry and I will be talking about the Depression in Mothers, More Than the Blues Toolkit. I will begin by providing the framework or the framing of the issue and talking about the rationale for the toolkit. And Dr. Perry will talk about the toolkit itself, as well as some tips and tools for frontline staff. But to actually begin and to have us in the right frame of mind on this International Women's Day, I'd like you to really go into your mind's eye and listen to Mary's story, or Marie's story. She was not sure when she started feeling this heaviness. But as she sat by the window holding her new baby, she felt the tears well in her eyes. And she felt the extreme sadness that overcame her. It was sunny outside, but inside it felt like a thunderstorm was coming. It was not more than 2 weeks since she had been alone. Her husband had to travel for his grandmother's sudden death. So she was home with a newborn, her firstborn. She was barely sleeping, but most of the days it took everything in her to breastfeed her child and to take care of her baby. She had thoughts. She had negative thoughts. On some days, she knew that she should be joyful for this wonderful gift, but it felt like the darkness was enveloping her. Nothing she did was right. Each day seems to be more and more trying to do the next thing for the child, but she felt that heaviness in her. As she held her baby in her lap, she thought to herself, this must be the baby blues the nurse talked about. But she knew it was more than baby blues. She just didn't know what it was. So maternal depression is not new to us. Based on the National Survey on Drug Use and Health, we know that approximately 10% worldwide women experience symptoms of depression. The World Health Organization in the most recent analysis even has a higher number of 20% of women experience some type of depression. And so today, our discussion is about what can we do. According to U.S. data, most women experience depression at some point in their life. Specifically, 1 in 5 women experience depression. And when we look among low-income women of color, 30 to 50% exhibit symptoms of depression. Now, when we overlay that within the rural context, we start to see the numbers even more alarming in a sense because of the small population. In rural communities, we know that there's an issue with accessibility, that not many families are able to have the transportation to mental health services, have the mental health services available to them. And when it is available, have the insurance available to really receive the screening that they need. And so based on our most current data from our Center for Behavioral Health Statistics, we see that 19% of residents in non-metropolitan counties reported a mental illness in the previous year. And when we drill down and look at specifically women, we see that among women aged 18 to 44 in rural communities, 10% reported a major depressive episode in the previous year. And then when we drill down even more and looked at pregnant women, we found that 4% reported a major depressive episode in the previous year. Now, for some of us hearing these numbers, it may appear that these percentages are very low. But when we think of what the population it represents, and when we think of what it tells us about once a woman gives birth, we know that it's a precursor to actual depression while the woman has a newborn. One of the things I wanted to point out is that while some of these estimates may not be true or underestimates of the true prevalence among pregnant women, it has significant implications for data that then we can collect from our pregnancy assessment system that tells us after birth that the numbers increase from 20 to even 60% of women with a newborn experiencing depression symptoms. There are several factors that link to depression. And again, we're overlaying rural settings, the accessibility, the availability with some of these factors. So issues of poverty, issues of discrimination that occur within rural communities, issues of migration from migrant workers coming from multiple distances who are now living, whether in Iowa or in Indiana or in Arkansas. We see that these factors now are leading to some increased risk for specific other disorders, but for increasing depression. We also see the overlay of exposure to violence as well as low social support that can happen when in rural communities families are isolated. Families, again, do not have transportation. And all of these factors are increasing the percentage of maternal depression that is occurring, but also having significant negative impact on parenting as well as on children. And when we look at the impact of depression, we know that it could be related to educational attainment by parents, income, and employment. But specifically, we know that it's really detrimental for young parents when it comes to attachment, when it comes to caregiving, when it comes to nurturing their child. And we also see some negative impact when we look at the child as far as outcome. We see some negative impact for young children when it comes to cognitive development, physical development, as well as social and emotional development. But there is some good news. And part of the good news comes from the World Health Organization. In their analysis of promising programs, they found that two approaches have worked. One is expanding the workforce that serve and support mothers. The other is integrating maternal programs through non-specialized or community health providers or frontline. And so they're seeing some significant improvement when it comes to improvement in mothers as well as improvement in child development when frontline staff are able to be trained and understand the symptoms of maternal depression and are able to intercede at crucial points with mothers. And so we at SAMHSA have developed this wonderful toolkit to really address some of these issues related to the high rates of depression in mothers with young children, with the fact that depression interferes with all areas of functioning from work to specifically parenting, and issues related to the growth and development of children whose mothers have significant maternal depression episodes. And so at this time, I'd like to pass it to my colleague to talk about the tool and to talk about the framework that shaped the tool, specifically how knowing, identifying, and doing really can change the trajectory of how we address maternal depression.
Thank you so much, Yannick. I appreciate you really setting the stage for this. I'm very pleased to be part of this esteemed panel. So as Yannick said, I'm going to share with you some of the details about the toolkit that was developed with support from SAMHSA, and I just want to do a shout out to a couple of my colleagues who helped develop this toolkit, specifically Bob Ammerman, Bill Beardsley, and Jeannie Miranda, and each of us have done a significant amount of work in communities that have been negatively impacted by maternal depression, and particularly, as Yannick mentioned, in rural communities where we know that the availability of specialized mental health personnel is just not, it's not available to most people. We felt that it was very important to create this toolkit to share with folks the kinds of strategies, the kinds of evidence-based strategies that we know can help mitigate depressive symptoms in moms. So I'm going to just kind of, as Monique said, start with the framework that we approach this with, and it really is a public health approach. And what we mean by that is that when we're thinking about the entire population, we're wanting to make sure that we're doing certain kinds of activities that target all mothers, because we don't know which mothers are going to become depressed or experience a high burden of depressive symptoms. So we want everyone to be sort of on the, looking out for all mothers, because even though we know which risk factors put women at higher risk for depression, we don't know individual women who are going to present with difficulty. We also want to have a set of tools and strategies to work with moms who are starting to show symptoms of depression but are not yet clinically depressed. And you can see that at the top of the triangle is a small percentage of women that varies, again, by context, as some of Yannick's data suggest, of moms who fall into the clinically significant depression. So the toolkit is designed to really help people think about how do we know who's falling into each of those categories and what should we be doing for them. So when we think about mental health promotion for all mothers, one of the most important things that we can do is really make sure that there's routine screening, both during the prenatal and the postpartum period. It's very important. We only recently had the American College of Obstetricians and Gynecologists endorse routine screening as part of prenatal care. I think many of us are shocked to hear that all pregnant women in the United States get a glucose test, even though only 4% of moms develop gestational diabetes, and yet many moms go without any prenatal depression screening when we see rates that are as high as 10, 12, 15, and 30, and 50% in our low-income communities of color. So this gap between screening and surveillance is very stark. And again, in rural communities, we need to make sure that whoever is delivering that prenatal care, whether it's a mid-level practitioner or a physician, is integrating screening during the prenatal and postpartum period. We also want to make sure that we help support all moms to do some basic things that are about self-care. So paying attention to their own needs. A lot of times women, as they're getting pregnant, are very focused on the baby and may not be as focused on themselves, and really making sure that they're eating well and being positive and getting support from family and friends. It's an important time to build that social support that Yannick was mentioning can be one of those risk factors for heightened depression in the postpartum period. We're recommending that people consider using a sort of a pair of screening tools called the Patient Health Questionnaire. This one is the PHQ-2, and it's just 2 simple questions that actually ask about the 2 kind of core symptoms of depression and maps nicely onto the Diagnostic and Statistical Manual criteria for depression. And we found that with many of our community-based providers, we've done some work with WIC, home visiting, midwives, and others. Only 2 questions isn't a big lift for people to ask, and this can help you start to identify who may need a little bit more screening and assessment. So the PHQ-2, the questions are here. They're available free. They've been translated into multiple languages, so that's available to everybody. Then if the mom says yes to one or more of those other questions, we are encouraging folks to follow up with what's called the PHQ-9. And this tool allows you to really get some actionable information about which of the symptoms folks are experiencing, and then also you can see here that these are the specific symptoms that we're looking for to make a more of a diagnostic assessment. And then I think the important question here, which is, if you've checked off any of those questions on the questionnaire, how difficult has it been for you to kind of get things done? And this functional impairment piece is a really important component of figuring out kind of how much the depression may be impacting on important parenting tasks and other tasks. What I like about the PHQ-9 is that it does give you sort of guidelines for action. And again, the PHQ-9 is free and translated into multiple languages. So with a mom whose score is below a 10, we're really not concerned about her at the present time, and that's where you can really offer some of those more mental health promotion strategies, make sure she's connected with some folks in terms of social support and things. When we get into the scores of like 10 to 14, that indicates minor depression. It's a moderate level of depressive symptoms, and that's where we have some specific tools and guidelines in the toolkit that can be really helpful for moms. Once you see a score of 15 or over, we really want to make a formal referral, and we can talk about that in the next few slides. And then severely depressed moms, we really want to make sure that they get connected to care right away, because we do have a very small percentage of moms who will experience postpartum psychosis or very significantly impairing depression. So the moms that the toolkit really focuses on, and it's a big majority of the moms who are experiencing perinatal, so depression during the prenatal and postpartum perinatal depression, those moms that are experiencing a lot of depressive symptoms but are not yet eligible for a clinical diagnosis. And as many of you know, our current behavioral health system is very diagnosis-driven. So even in those cases where you might have access to formal mental health specialists, unless the patient is meeting clinically significant levels of depression, they might not be able to get in for treatment. And, we have long waits for that. So these moms who have a lot of depressive symptoms, we have basically extracted a bunch of materials that come out of the cognitive behavioral therapy literature, and there's a whole set of activities about the importance of adding more pleasant activities to moms' daily routines. Also, connecting people to social support systems, and then also adding different kinds of relaxation activities in to help them manage their stress. And a lot of this work comes out of some work that we've done called the Mothers and Babies course. The Mothers and Babies course takes the cognitive behavioral framework and gives lots of different kinds of tips and tools for folks to use both in group settings, but also some colleagues of ours at Northwestern University have broken it down into one-on-one visits. And I think particularly in rural settings, those one-on-one options for the Mothers and Babies course can be a very powerful way to do some more structured intervention for these moms. I think the other thing that we've discovered across our different work is how important it is to really check in with moms about her emotional state. And a lot of times what we hear from folks, particularly those who are not mental health specialists or not trained in mental health, are people feel awkward or anxious about sort of how to frame those questions. And so in the toolkit we have a number of different examples of sort of what to say, how to start a conversation. Things like starting with something that's objective, like you seem down or irritable this week. How are you doing? Is everything okay? Or things like, has your mood been affecting your parenting? So these are some examples of words that we have found our frontline people find helpful in starting some conversations that they often feel a little bit intimidated about. Back to the pleasant activities, one of the things that is true about sort of a cognitive behavioral approach to addressing depression is that as people start to experience more and more depression, they start to withdraw and stop doing things that used to give them pleasure. And this can actually start a downward cycle so that as people pull back away from things that used to give them pleasure, then their mood declines even more. And what we want to do with these activities that are in the toolkit are to reverse that chain. So to start the chain of positive experiences so that when you do a pleasant activity, that then can lead to more positive mood, which could then help you combat some negative thoughts and have more positive experiences. So what we do is we have tools in there to help each of you work with moms to have them actually schedule 1 or 2 pleasant activities every day, even if they're things just like putting music on in the kitchen and dancing around, or taking a 5-minute break from all of the things that are stressing you out. We try to encourage moms to think of low and no-cost activities, things they can do with their baby if they're in the postpartum period, or things they can do with others, or things they can do on their own. And so there's lots of different tools in the toolbox to help structure those kinds of conversations. Just want to spend a little bit of time talking about how important it is for us to connect moms to mental health services if we suspect that they're experiencing a very high burden of depressive symptoms. And what we've actually encouraged people to think about is to not refer directly to community mental health systems if those services aren't available, but to start really with mom's primary care doctor or even her child's pediatrician. More and more pediatricians are able to bill for maternal depression screens as part of an expanded developmental assessment, because the research literature on the long-term negative effects of maternal depression for children's health and wellness is very, very well documented. I think the other thing we want to make sure that each of you has taken time to do as providers, frontline providers working with these families, is to have a really good customized list of other kinds of referrals that you can help connect moms to. We know that referring moms to mental health can be really challenging. Not all moms are ready for treatment, and that's why we've come to this place where we really are trying to have a very broad set of places where we can refer moms who may be experiencing some depressive symptoms but are not yet clinically depressed. They may have had negative experiences in the past. A lot of times we hear moms say, I'm just going to wait until it's, it's not bad enough. I'm going to wait. And sometimes, the first place they go isn't a good fit. And so as frontline providers working with families, we need to be listening for those kinds of things. What are some of the concerns? What are some of the barriers? Is transportation a barrier? Is the cost of care a barrier? A lot of times we hear, particularly in the postpartum period, that moms are reluctant to take antidepressant medications, especially if they're breastfeeding. And there's a lot of good information out there about the safety of doing that, particularly for moms who really are experiencing a lot of symptoms. And then we always, I think, are, continuing to combat negative societal attitudes about mental illness and helping kind of demysticize mental health and give people a place to talk about trauma in a way that can help them on the road to recovery. So this is the cover of the toolkit. It's available for download at the SAMHSA website, and we're really excited. You know, SAMHSA has been such a supporter of this work, and the outpouring of interest in this toolkit has been so substantial that we've now made this available in Spanish and English. So there's a lot of different kinds of things that are useful for you. I mentioned the pleasant activities. There's other ideas about how to improve mom's mood and manage stress. There are some little case studies of examples from Early Head Start and Head Start, as well as WIC, the Women, Infant, and Children Nutritional Program, and home visiting. There's lots of links to scientific articles and other websites. So really just want to encourage you all to download it, see how these tools can be integrated into your practice. And ultimately what we're trying to do is just support moms who can be the happy, raise happy, healthy babies and do that kind of responsive parenting that Yannick was talking about. And especially in rural communities, the frontline folks are perfectly positioned to play an important role in promoting positive well-being for these families. So I think we're going to stop here. I'm going to hand it off, see if there are any specific questions about the materials that Yannick and I have presented before we hear from our colleagues in Colorado.
So, Deborah, this is Karen. We had one question come through the Q&A asking who administers the patient health questionnaire?
Yeah, so the nice thing about the patient health questionnaire is that anybody can administer that. It's for lay people. We have had WIC workers administer the PHQ-2 as part of their intake. We have home visitors, both paraprofessional and others, administering the PHQ-2 and the PHQ-9. So we've had Head Start professionals, people in child care programs. So really anybody can administer that. I also see that Maureen has a question about the EPDS, which is the Edinburgh Postnatal Depression Scale. And the EPDS is also a very good tool. The reason that we are recommending the PHQ is because it can be used for mothers who are not in the perinatal, prenatal, and postpartum period, as well as other caregivers who may be raising children. So we always, whenever I talk about these kinds of things, I always hear about what about the dads? Don't forget the dads. So the PHQ-9 can be a tool that can be used across different caregivers. I also see that Brooke was asking where you can get copies of these assessments. The nice thing is that all of them are available free on the internet. All you have to do is Google them, particularly the PHQ-9. There's a really nice a toolkit that was developed by the MacArthur Foundation that gives you a lot of detail about how to kind of put the PHQ-9 into action, and we can post that link in the Q&A as soon as I stop talking, because I can't do both of those things at once.
And Debbie, we also, as part, once we send the slides, we know that CDC has a web page that has a lot of resources, and one of them that they have is a link to a lot of these particular screeners as well as others for maternal depression. So we can include a link to that, to the slides also.
And so I'd also like to point out to all our participants this afternoon that all of the resources that we mentioned, here on the webinar this afternoon. We will post the links of those resources on the Rural Behavioral Health portal, and we will provide you with the link to the portal at the end of the presentation this afternoon.
Okay, I also see that there's a question from Lisa about how many months after childbirth is it common to see postpartum depression. The truth is that there's a couple of different peaks in the postpartum period where we see maternal depression coming up. And so as Yannick mentioned in her case study, which was such a nice way to start, Yannick, we often hear about the baby blues, and somewhere around 70 to 80% of all mothers experience baby blues. And that's really in the first 2 weeks postpartum, where there's such a big change between pregnancy hormones and breastfeeding hormones. And I like to often remind people that sleep deprivation is a form of torture under the Geneva Conventions, and nobody's sleeping those first few weeks postpartum. And so that period is not a good time to screen for depression, because everybody is likely to screen high on some of those symptoms. But it's really in like the 6 to 8 week period where we start to really see more significant depression starting to emerge. And then more recently, we've also noticed that at the 3 to 4 month period, there's another peak. And some people have hypothesized that that may be because that's when a lot of people, if they've had any time off at all, are starting to go back to work and really wrestle with the realities of full-time work and full-time parenting. Yes, and I see that Tammy talked about a book that Brooke Shields did, a really terrific book, I agree, Tammy, called Down Came the Rain, which is her personal account of her experience with postpartum depression. Really, really excellent. We actually have a little snapshot of that from in the toolkit, because I too felt like it was a really great account of how difficult that can be.
Oh, you said something. Can we read it? We have one more question, but Tammy indicated that she experienced postpartum, and some of her thoughts, I guess some of Mary's thoughts were similar. We had a question regarding once you conduct the PHQ-2, what happens, what's the next step? I think the toolkit really has some resources for what you do next, but one of the things that is important is that you do develop as far as a system in place for what happens, what kind of referral is available. Do you link to primary care? Do you link to behavioral health in your community? What is the network of systems that's in place given the rural setting, and determine what is the appropriate next steps for the response. And again, as Deb went through and told us the different levels, and some of it may require, again, just lay people who've been trained with this, whether it's if you have home visiting programs in place that may be able to, at that zero below, that's, level where it's just symptoms and not clinical depression, that you can intervene on your own. But if it's that next level where you really need to get them linked to, a specialist, then make sure that you have a system in place and you have referrals in place.
Great. So I think I'm going to put myself on mute, and I'm going to let the Colorado folks share some of their strategies for addressing this important issue in their settings.
And we can address some questions after the Colorado team also.
So Fulong, please go ahead.
Oh, okay. Thank you, Karen. Thank you, Deborah and Unique, for the opportunity today. And good afternoon, everyone. My name is Fulan Nguyen, and I work at the Colorado Department of Public Health and Environment. My work here entails being a young child wellness specialist for Colorado Project Launch, as well as being part of the maternal wellness team here that works on pregnancy-related depression as part of our state's maternal and child health Title V block grant. Emily Anderson is my co-presenter. She leads the pregnancy-related depression work at Chaffee County Public Health. Emily is a home visiting nurse and also a lactation counselor, among other things. So her work at Chaffee County Public Health really covers the whole gamut that is maternal mental health. Thank you again. So just a little bit to start us off in terms of the context of what Colorado is all about. As many of you may know, we are a very large state. We are, in fact, the 8th largest state in terms of land mass, to be exact. We have 64 counties, most of which are designated as isolated rural or frontier communities, and 55 counties of which have been designated as mental health professional shortage areas. So in our state, because we are so spread out, we do strive for local autonomy and local independence. So our local approaches to addressing issues, whether it's a public health issue or governance, is very also unique to each community. This is both a unique feature of Colorado as well as a challenge, especially when it comes to access and resources in smaller communities and also in terms of data and surveillance. So statewide, our latest data from the Pregnancy Risk Assessment Monitoring System, or PRAMS, indicate that there are more than 1 in 10 women who are affected by pregnancy-related depression and anxiety. As Unique mentioned earlier, we know that the actual prevalence of pregnancy-related depression is likely to be much higher, and that is partly because of the barriers around women's reluctance to talk about their symptoms openly for fear of being judged or feeling socially excluded. But even with those estimates from the survey, self-report data, we know that the impact of PRD also lies with thousands of children who are born to moms who are affected by PRD. So in Colorado, between 2012 and 2014, there were nearly 20,000 children who were born to moms who experienced depression. So as such, in Colorado, we believe that addressing moms' mental health has to be an integral part of addressing and building young children's mental health and well-being. So in Colorado, as I think in many states, there are several primary data sources that we look to better understand the extent to which Colorado women are affected by pregnancy-related depression and anxiety. So our most recent data from our PRAMS system indicates that 77.6% of mothers who report that a healthcare worker talked with them about what to do if they felt depressed during pregnancy or after delivery. Our state goal, and that's through our MCH action plan, is to increase that figure to 85.8% by 2020. So among those moms who reported feeling depressive symptoms during pregnancy or after they deliver their babies, some of the top risk factors, and we've heard Unique talk about this before, intimate partner violence, homelessness or housing insecurity issues, economic hardships like trouble paying bills, and then smoking throughout the perinatal period is another risk factor. We're looking at the data from the behavioral risk surveillance system. We see that about 23%, and that's actually more than 1 out of 5 Colorado women of reproductive age who report that they were told to have had depression. Now, in some of our more rural areas, these figures could be as high as 30 or 40%. The third data point that we have is through the Colorado Health Access Survey, which indicates about 13.3% who at one point said that there was a time in the past 12 months that they did not get any therapy or counseling that they actually needed. Of those women, almost 2/3 said that cost is a major concern for them not getting the help they needed. More than half said that they had a really hard time getting appointments. Nearly half said they didn't feel comfortable talking to a healthcare professional, or they didn't think that insurance would cover the cost for counseling. And then more than 1/3 said they were concerned about what would happen, again, if somebody found out or somebody knew they needed help. Most recently, the State Health Department released a report and data from the Colorado Maternal Mortality Program, which indicates that about 1/3 or 30% of pregnancy-associated deaths in Colorado between 2004 and 2012 are actually attributed to accidental overdose or suicide. So what we're talking about here is more specifically that these maternal deaths were actually associated with women who had documented psychiatric conditions, women who had known substance use disorder, or had previously attempted suicide, or had were taking medications at conception for depression, but had discontinued medications during pregnancy. So obviously all this data, the point of all this data is to say that the consequences are pretty significant and pretty grave for both moms and children if pregnancy-related depression goes unaddressed. So over the past couple of decades, and some of my colleagues and my supervisor might disagree that it's only been a couple of decades, but it's been a long time. Colorado has been working to increase the number of women screened and referred for treatment for pregnancy-related depression. Increasingly, we are encouraged to see that more and more providers are conducting at least one depression screen as a standard protocol in either a prenatal or pediatric setting. So this really reflects the national practice and is very much consistent with recommendations from the national association like the American Academy of Pediatrics and the American Congress of Obstetricians and Gynecologists, and most recently the U.S. Preventive Services Task Force. Encouraging a variety of providers and in different settings to screen for and identify early symptoms of PRD is also something that is consistent with best practices that, as outlined by Deb in the Depression in Mothers Toolkit that we talked about earlier. So for the 2016-2020 MCH grant cycle, our state's overarching goal is to reduce the social exclusion that is associated with maternal mental health throughout the state, to increase the number of women who seek help for PRD. We have two primary strategies to reach that goal, and one is to develop and implement a public awareness initiative to decrease affected women's sense of self-exclusion and to build awareness for them to seek help. And secondly, to strengthen the referral networks for providers across the state to address PRD, and that is at both the state level and at the local levels. We've been working really hard, and part of our role here as a state health department is to work very closely with local partners to encourage, local solutions and innovative approaches that are tailored and culturally relevant to each community. And our role is also to make sure that our partners, and again, especially those in the rural communities, have access to, comprehensive, diverse, evidence-based menu of tools and resources like the toolkit, so that they can do their best work at the local level when we're not able to be there. So, and to date, we have distributed and shared with about 14 local public health partners the toolkit, and those partners cover an array of geographic locations across the state, urban, rural, frontier, and the whole gamut, the whole state. I'm going to stop for a bit and hand this over now to Emily, who is going to showcase a pilot program in her community to demonstrate how Chaffee County, as a very rural community, has adapted some of these practices and resources and tools to create their own, pilot program around screening, referral, and treatment for PRD. And just a little context for those of you who are not familiar with Colorado, Chaffee County is about 3.5 hours southwest of Denver, which is the capital. Chaffee County, I looked it up, it's about the size of the state of Massachusetts, but have a spread out population of about 20,000. So with that, I'm going to hand it over to Emily.
All right, great. Thank you, Fulan. As she said, my name is Emily, and I am a nurse at Chaffee County Public Health. Chaffee County is where I grew up. I've lived here most of my life, and now I get to work here and raise a family here. So I have a huge passion for rural health. Chaffee County consists of two main towns, one on the north end and one on the south end of the county, about a 30-minute drive from each other. Maternal mental health is a passion of mine. I'm a home visit nurse and have spent hours and hours with new moms, and it became clear to myself and one of my colleagues that there needed to be a better system for detecting and treating women with depression and anxiety. So about a year and a half ago, we partnered with the Early Childhood Council to increase screening and improve referrals and follow-up for pregnancy-related depression and anxiety. Our goal, and it's very lofty, I realize, is that 100% of women in Chaffee County are screened for pregnancy-related depression and then referred to mental health counseling and other services if necessary. It sounds like a huge goal, but when you think about a small county like ours with only 130 to 150 births a year and only 8 physicians that deliver babies, we really feel like we can make it happen. So to go through a little bit of the pilot program, it's a 6-month pilot. It started this month and will go through August. We are working with our 4 primary care offices with a total of 8 physicians. We are asking them to screen at least once prenatally and at least once postpartum, hopefully more, and have offered a lot of guidance on all the possible times to screen, reasons why that might be a good time. We're asking the practices to determine what they think will work best. We're also offering them guidance for developing an office protocol to incorporate these screening practices, as well as an algorithm and cheat sheet of what to do when a woman screens at certain levels on either the PHQ-9 or the Edinburgh screening tool. So all the information that we used for the doctor packets, as we call them, came from a variety of national and state resources, including the Depression in Mothers Toolkit. We also are offering folders to be given to the women once prenatally and once postpartum. These folders have what we found to be the best information on PRD, blog articles, self-care strategies, how to talk to your doctor, and then all of our local mental health providers and support programs. So our accomplishments, though the pilot program just started, there's been a lot of back work that has gone into this. So the first accomplishment, I would say, was a thorough assessment. We didn't want to spring this on doctors without understanding what their challenges were. So we, my coworker and I, we called all of them and had about hour-long conversations with each physician about their current screening and referral practices, the challenges that they face, and what they would need from public health in regards to screening, referral, and follow-up. So we not only got an accurate picture of the state of maternal mental health practices in our county, but we also started to get buy-in for our future pilot program. Another huge accomplishment, and this is to me a great advantage of being in a rural community, are we have physician and nurse champions at every single practice. So as we were developing this pilot program, the physicians, one at each practice, were involved heavily in critiquing what we put together, asking us to add things and change things. We felt it was very important that we didn't develop materials that were inaccurate or not applicable to their practices. And then we've also cultivated relationships with their nurses or case managers at each office, as they are often the ones responsible for incorporating screening, referral, and follow-up practices. And then, of course, the materials provided, we've been working on them for a year and a half, and we're very, very proud of them. And I think that there isn't a single thing we have offered that doesn't have some really good use. Now, there's certainly been challenges as well. There is not consistent guidelines on when to screen. We have everything from once in the pregnancy or once postpartum to every well-child visit. So we put together a document that explains all the different suggestions and reasons why they might consider screening at a certain time. So, for example, screening at a well-child visit as opposed to just the 6-week postpartum visit. One, you can catch women who may develop symptoms later in their postpartum period, and 2, we've heard it's a way for women to feel like it's okay to talk about myself even though I'm here for my child's well-child visit, because from what we've heard, a lot of women feel like they go to their 6-week postpartum visit, and then it's like no one cares about them anymore. It's all about the baby, and we all know that recovering from childbirth is a much longer than 6-week process. Another challenge is the physician's perception about need for formal screening. Most of the physicians agreed that there is a need for formal and consistent screening, but there were some older physicians who did feel like they knew their patients well enough to detect depression and anxiety without a tool. Mental health referrals, we are a mental health provider shortage area. We have about half as many per person as the state average, so that's a huge problem. And we're finding that women are getting referred and the people they're being referred to are full. So that is a big problem. Insurance coverage is also always a potential problem. Chaffee County has a very high cost of living, but quite a bit lower wages than the state average, so money here is always an issue. And then probably one of the most challenging is simply changing the office protocol and sustaining that over time. So you may have everyone interested and agreeable that screening and referral is important, but how do you know that in a month from now, when the memory of us talking about it is off their minds, that tool isn't just put on a shelf somewhere? So that's why we are doing a lot of follow-up and helping them develop a protocol that fits their office versus us just telling them how we think they should do it. So that's it in a nutshell. Thank you guys so much for listening, and I'd be happy to answer any questions at a later time.
Thanks, Emily. And this is back to Fulan again. Thanks, Emily, for sharing that local perspective. It's really exciting to see the localized solution to really a statewide issue. Now I'd like for us to kind of zoom back out to talk about some statewide efforts and some statewide work, in particular our public awareness campaign that is aimed at supporting and strengthening the local work that's happening, but all at the same time it's our population level public health attempt to address and hopefully reduce the overall perception that women affected by PRD feels around social exclusion and judgment and that kind of thing. So we began this effort with a market research study back in 2015 that included a variety of professionals, providers, as well as affected moms and their support systems. We tested messages and images to determine how affected women understood PRD overall, the level and type of knowledge and awareness that they had about symptoms, and also their attitudes and beliefs about help seeking. We also conducted focus group with African American women in the metro area. So based on those findings, we were able to implement a pilot campaign that actually just ended. It started in October, and we just ended it in January, and in partnership with 3 local public health agencies. The goals of the campaign are to, 1, to improve affected women's awareness and knowledge about PRD, and 2, to improve their perceptions and attitudes towards seeking help and treatment for PRD. Our target audience includes affected moms as well as their informal support network. Now, so this campaign of ours is actually a digital campaign, and it's being hosted by our partner, Postpartum Support International, or PSI. And PSI provides us with a landing page for our target audiences, in this case, affected moms and informal supports. When we complete the pilot campaign at the end of January, we'll start to actually, so we just wrapped up our pilot phase, and we will start back up again this month, and we'll go through the summer. Our campaigns for our expanded phase, past the pilot phase, will remain the same. But what we are doing differently is we will be expanding our campaign into additional communities, and we're happy to say that Chaffee is going to be one of those communities who's going to be helping us implement this campaign in a vastly, culturally, socially, geographically different community. So we're very happy to have them on board to help us expand the reach and of the messages of the campaign. So in addition to directing affected women and their support systems persons to contact PSI for help, we also provide Colorado-specific resources and information, about a variety of things like support groups, and try to connect them to our Colorado PSI network of maternal mental health experts who then either provide direct services or facilitate referrals. Our campaign also includes tapping into digital online platforms, things like Facebook, Twitter, and blogs. These are places where we know that pregnant and new moms go nowadays to interact with other moms and where they go to seek mutual help and support. As part of our working together with our local communities to implement the public awareness campaign, we've also developed a full suite of creative assets and resources. So we have things like posters, fact sheets, talking points, flyers, business cards, again, for both affected moms as well as their support systems. One communication tactic that we've been particularly successful at and we particularly like a lot is this notion of building a cadre of spokespeople. These are affected moms and dads who have stepped up and volunteered to share their stories and their experiences, and then what they also do is they encourage others to speak up to seek help. We're very excited that very recently our campaign this story was recently picked up and highlighted by one of the three major network TV stations here in Colorado. So when you have a moment, you can click on that picture right there, and you can watch the video of this health reporter interviewing one of our campaign spokesmom and also her spouse about their experience with pregnancy-related depression and anxiety and how they are encouraging other moms and dads to seek help and support. So we here in Colorado, we feel very lucky to have so many opportunities and so many resources and partners that are on the same page, all working to build the health and well-being of moms, of kiddos, of communities. For example, we're excited to have, resources and partners at all levels of state and local communities. So we have Project Launch, we have Launch Together, which is our sister initiative that's being funded privately, but it's also being implemented through Chafee again, another connection, but also in additional communities. We're also partnering with folks working on the State Innovation Model, a SIM grant, and in the upcoming years we'll be working with additional partners to start looking at and start implementing some of the Medicaid reform measures to improve health and behavioral health integration, again, with the goals to support moms, kiddos, families, and communities across the state. And those are just more partners and resources and collaborators and efforts that are all going towards achieving, our goal. Let's see, these are some of our resources that you can look at. I believe there's lots of stuff. There were actually more that I didn't include. And that's it. So thank you for listening to Emily and I and for this opportunity to share some of the nuggets that we have here in Colorado. We could go on and on and talk a lot more about Colorado, but we will leave that up to you to reach out if you have any questions or thoughts to share with us. So thank you so much. I'll turn it back to Kim now.
Thank you, Long, and thank you, Emily. Just one question that came up from your section is Fremont County only one of the 55 with the mental health professional shortage?
So is the question is Chafee one of the only, is Chafee or Fremont? So Chafee and Fremont are
one of the 55 with the mental health professional shortage. So is there a shortage of mental health professionals in Fremont County?
I don't have that off the top of my head, but my guess would be yes, very likely. Emily, do you know?
I would also guess yes. We're often lumped together as Region 13 with Fremont County, right. So I would imagine so.
Yeah.
And then just another question for Yannick or Deborah. Is there a focus in the toolkit on teen moms?
So there is not a focus in the toolkit on teen moms, but the work that the toolkit is based on has been done with teen moms as well, and there is some adaptation work being done specifically to tailor some of the additional strategies for mothers and babies for teen moms, but the strategies that are in the toolkit would work very well with teen moms as well.
Thank you, Debbie, for that. I wanted to emphasize that that's one of the wonderful pieces about the toolkit is that it can be enhanced and can be not modified, but actually supplemented to specific communities, because I know even Project Launch has several tribal communities, and they've used it, components of it in the work that they're doing with centering pregnancy, as well as incorporating also as part of the toolkit the work around fathers who have depression. And so the toolkit gives you that flexibility to really apply it in multiple settings, whether it be our territories that are also rural, our Pacific jurisdictions that are also rural, in addition to U.S. Communities that are rural, that you can really modify it. And the thing that we want to emphasize is that the toolkit allows you to think about what are the natural systems around women and families that you can tap and train and use the toolkit to really provide that support to mothers. And so not just the social service systems or the professional system, but the natural system, whether it is working with libraries, whether it's working, again, we said the post office, the natural systems that connect with families that you want to really make part of your collaborative work around awareness on maternal depression and as far as support for women and for families.
Well, thank you, Unique. So we have two other questions here. The first one is that would you mind, at your convenience, reposting the link for the MacArthur Patient Health Questionnaire Toolkit? And we will post all of the resources, again, as we've talked, as have been mentioned on the webinar, to the Rural Behavioral Health Webinar platform, as well as we will also send out an email with all of the links. And so the next question here also is for you, Emily. You said that providers you outreach to were primary care providers. Did these include pediatricians, and why not OBs? What do you think was the benefit of using this place of service?
Great question. We don't have any pediatricians or OBs. So the only doctors we have delivering babies and taking care of them after they're born are primary care doctors.
Okay. Makes sense.
Mm-hmm.
All right. Okay. So I am told that the functionality of our polling questions, now work. So, we would just ask you, we're going to take the front and put it to the back here, and ask if you just take a few minutes just to tell us a little bit about, about the region of the U.S. that your community is located in, and then we'd also like to ask you to respond to a second polling question, which will give us some idea of the role that you play in your communities. So the first polling question is, in what region of the U.S. is your community located? Almost finished. Okay. All righty, just a few more. We can tally that. Okay, well, thank you so much for your responses. And I see here that we have representation from all regions within throughout our community. So again, thank you for joining us. And the next question is, what is your role in your program or your community? You just take a few minutes to respond to that. All right. And so we're just taking some time just to record responses here. And again, here I'd say that we have, representation from, wide range of roles within communities. We don't have that many representation of family and youth on the call this afternoon, but, we definitely have, representation from our clinicians, individuals who are in management roles, a number of consumers, and individuals representing federal, state, or local policymakers. So thanks again for joining us. So, I'd like to turn this webinar back over to any of our presenters, if to share with us any, final thoughts that you have as it relates to, this presentation or any of the questions that have been posed to us. So, Yannick, I'll start with you, and then we can go to Deborah, and then to Flong, and then Emily.
So thank you, everyone who's hung on to this last few minutes of the call. And so we appreciate you taking the time to participate because, as we said, we consider maternal depression to be a significant public health challenge. And it's a challenge that I think requires us to think creatively, requires us to think about what are the natural systems around women and families, and also requires us to think of what are the best approaches that we can partner with women. And so having a tool that capitalizes not just on clinicians, but frontline staff that may have day-to-day contact, regular contact with women while they're pregnant and after birth is really important. And so this toolkit, again, can be modified to serve and to really lay out how you can address maternal depression in your rural community. We also want to ask you to send us information if there are ways that you are already using this toolkit, if you've used this toolkit, or if there are ways that you are addressing maternal depression in your community. We would like to know more about it, so please send us information following this. So I'd like to also thank my colleagues who are very knowledgeable about the work that's getting done. Again, Dr. Deborah Perry, who is, again, really helped to develop this wonderful tool and has been doing a lot of work with women in depression, and so I'm honored to be part of this webinar. And then our colleagues here, Karen Francis, Josh Sebian, and Laura, who you did not get to see, but has been really managing our webinar. And then my launch partners, Fulong and Emily. We really appreciate them being able to present to you what is happening on the ground, how they use the toolkit, how they're really changing how they address this issue. So we thank you, and please send us stories about how you're addressing maternal depression, because it impacts all of us. And we know, though, there's some positive things that are getting done in multiple communities internationally, working with lay people to really touch the lives of women.
So, Deborah, any closing comments?
No, I would just like to also echo Yannick's comments and just thank everybody who hung in there with us for this presentation. We will definitely post a number of different follow-up links and resources to support the very important work that you're doing in rural parts of the United States. So thank you for what you do every day.
And so long before I close out the webinar, or Emily, any?
Yeah. My only comments would be just to, again, give kudos to our partners here and the alignment that we have with partners at both the local and state levels in terms of the public health partners that we have, as well as the early childhood partners that we have. I just feel like we are really make the connections across sectors, across systems, and across providers is really benefiting, that's going to benefit families and children. So it's a really coordinated, and it's a good concert to be, to be observing and to be a part of.
All right, so, we have a few more minutes here, and Laura, if I could just ask you to, go to the slide with the participant feedback so that, as I close this webinar out, I would ask, participants if you could just click on that participant feedback link to provide us with some feedback about today's webinar and how you thought that it went. We are very interested in getting your feedback because we use this feedback to help us in the planning and conducting of, of future webinars. So, while you're doing that, again, I'd just like to say thank you so much for joining us this afternoon. As promised, all of the links to all of the information and the resources that we talked about and that were presented on the webinar today will be made available to you on the ruralbehavioralhealth.org website. And we will, again, as I said, send the link out for you to access all of the materials on the site. And I'd also encourage you all to join us again for, additional webinars in the 2017 Rural Behavioral Health Webinar Series. We have 3 other webinars coming up. The first will on May 17th. It will be providing culturally and linguistically competent behavioral health services to diverse populations in rural communities. And then on June 21st, we'll be presenting a webinar on responding to natural disasters in rural communities. And then on August 16th, we will focus on suicide prevention in rural communities. And again, we have the website, the link for you